comorbid illness, chronic disease in the family characteristics, like type of family and living or not living with a life partner were recorded, educational qualification, rural, urban residence, employment status, monthly income. So all this was assessed as a part of the socio-economic status as per the latest Kupuswamy scale of 2017. And disease factors, as we know in Parkinson's, like age of onset of disease, the duration of disease, the severity of the on the basis of the ONNR, ONNR staging, UPDRS-3, these were also recorded. Detailed treatment history based on what medications, which group of drugs is going on, the total pill burden, the levodopa equivalent daily dose, this was also recorded. Adverse drug events were also assessed using a proper questionnaire, and the definition of adverse drug events was used as per WHO, which is these are medical occurrences temporarily associated with the use of a medicinal product, but not necessarily causally related. Compliance. So this was something interesting because not a lot of studies evaluate this. So what they did was whether the patient is compliant for a hospital visit in their neurology OPD was classified as regular or irregular. So what is regular? That those who have missed less than or equal to 3 scheduled appointments. So these guys are the regular follow-up, and those who missed more than 3 in the past 1 year were defined as irregular. But people who missed the follow-up visits because of COVID, they were not classified as irregular. And people who visited the OPD prior to their scheduled appointment were also considered as a proper visit. Depression was assessed in all the patients using a GDS, short form geriatric depression scale. So this is a screening scale for identifying depression in PD. It is recommended by the Movement Disorder Society. So very simple 15-item questionnaire, yes or no. So anything that indicates depression was given a score of 1. And if you have a score of more than 5, then it is considered as having, they are considered as having depression. And another very important point coming to the main core of this study is the adherence assessment. So what they did was they used a scale called Moresky Medication Adherence Scale called MMAS-8. This was actually developed for testing adherence in antihypertensive drugs, like in patients of hypertension. So the same thing was used. It's also a very simple scale. You have a scoring from, you have 8 questions and a total of like first 7 is a yes or no. And the last is scored on a 5-point Likert type scale. So based on that, you can categorize patients into high adherence, medium, and low. So high adherence means score of 0. So they like the questions are like, have you missed your pill? So if the answer is no, so it would be 0. So the lower the score, so higher the adherence. So high adherence is a score of 0, medium is score of 1 to 2, and low is anything more than 2. So this is the scale. This was developed for hypertension. So the questions are like that. Do you sometimes forget to take your pills? Have you ever cut back or stopped your medication without telling your doctor? Important thing is it checks intentional as well as unintentional. So let's say somebody is having giddiness or some adverse drug effect and he has deliberately stopped it. That would also be counted as non-adherence. So, or it can be simple forgetfulness also. So intentional and unintentional both is included in this scale. So the statistical analysis was done using the IBM SPSS Statistics 26. All the demographic and clinical parameters were analyzed. The range and median of HNY stages were calculated. Then the statistical analysis has been done properly, as I could assess, because the categorical variables were analyzed with the chi-square. The quantitative variables were analyzed using the analysis of variance, ANOVA. A univariate analysis was done with all the parameters associated with adherence using chi-square, ANOVA, and t-tests. Then a multiple regression analysis was performed to find out the independent predictors of adherence. And then a Spearman's rank correlation coefficient was used to measure the strength of correlation in the factors which were found to be independent predictors. And the p-value was less than 0.05. So this is just the table. I will not focus on this. I'll just come to the important aspects. So what they did was they had 147 patients. 15 patients were excluded because these are the 15 patients because of they had history of overuse of dopaminergic drugs such as impulse control disorders. And the remaining number of patients, that is 132, they were either adherent, which is a high adherence, and medium and low, they were classified as non-adherent. So it came down to 43% of patients were adherent, 18% were medium adherent, and 38 or 39% were low adherent. All right. So now coming to important findings. One, on the analysis, they found out that the association of adherence to therapy was there was a significant association with the hospital follow-up visits. So the people who had a regular follow-up, because they tested compliance, those who had a regular follow-up, they were good on the adherence scale. It was significant, less than 0.05. When those who were irregular in follow-up had a poor compliance. And another factor which was associated with poor adherence was presence of adverse drug events, ADEs, and depressive symptoms. So three important things. One, poor follow-up. Those who don't follow up properly are more likely to miss their doses at home also. Those who have depressive symptoms are likely to not comply with therapy. And third, those who experience adverse drug events. So these are three important things which were found to be statistically significant. And on a multiple regression analysis, it was depression, which was the strongest and the independent predictor. P-value you can see is less than 0.0001 of poor adherence in this study. They also did a Spearman's rank coefficient to test the correlation, how strong it was, and it was pretty significant. It was 0.7. So this is a scatter plot. What it just tells us is that as the medication adherence decreases, the severity of depression increases, and vice versa also. So as the severity of depression increases, the adherence goes down. So some important findings, sometimes we may have a good insight because of some negative findings, like the authors did not find any demographic factors to affect the adherence pattern, like the age, gender, educational qualification, and employment status. I'll come to the reasons why the authors thought this was important finding. Again, there was no differences in the disease factors, like duration of disease, the score on UPDRS, or the pill burden, or the LEDD, and there was no significant association of these factors with the adherence. And even some factors, like in this study, they found out that socioeconomic status, rural or urban residents, whether they have a life partner or not, whether their life partner has comorbid illnesses or not, these factors also did not have any significant association with adherence to medication. So just coming to the last end of the presentation. So we all know that non-adherence to medication in PD leads to higher readmission rates and reduced quality of life. So adherence is important. 43.2% had a good adherence. 18.2 were in the medium range. Why this group is important is because with a little bit of effort, you can push these guys into the high adherence group, and low adherence was seen among 38.6%. Across the world, a lot of studies have been done in the developed world, and they have found different range between 10 to 67%. So it's a pretty wide range. Presence of adverse drug events has been one of the most significant barriers in patients' medications behavior. So if they have ADEs, they are unlikely to have a good compliance. Other factors like LEDD and pill burden had no association. And as I mentioned, apart from ADEs, poor adherence was found to be seen in patients who had an irregular follow-up. Apart from that, those who had depression also had a poor adherence. So hence, if you can deal with depression, the follow-up, ensure their compliance, and try to educate them about the adverse drug events, these are the three things which may improve adherence in these patients. And obviously, the study was not without limitations. They have said that because it was a questionnaire, it's subjective. So it can be an overestimate. They can still overestimate their adherence because it can be a recall bias. I mean, if they have been following up after a long time, they may overestimate their adherence. Obviously, you can use better methods like electronic monitoring and other things, but that is open to discussion. So coming to in brief, critical appraisal, yes, the criteria for inclusion in the sample was very clearly defined as we discussed. The study subjects and their setting was also described in detail. Objective standard criteria were used for measurement of condition, yes. Just a brief mention, which I felt I could add, was that when we use UPDRS and these scales, they have used mean with standard deviation, but a UPDRS score of, let's say, 53.8 means nothing. So maybe ordinal scales with a sort of a quartile in the form of median with the interquartile range would have been a better way of representing that data. Confounding factors, were they identified? Yes, because you see, adverse drug events and irregular follow-up, they are mutually inclusive of each other. They are confounding. So people who have adverse drug events will have an irregular follow-up, and those who are irregular in follow-up, they may not be educated about these things. So they may have these more and may not have any corrective measures for that. So for that, the strategies the authors have used, they used a multivariate analysis. to highlight the confounding effect. And at the end, it was depression, which was found to be an independent predictor of poor adherence. Were the outcomes measured in a valid and reliable way? Yes. Was appropriate statistical analysis used? Yes. They used proper analysis, but just a brief mention is that they have not exactly mentioned what they used. I mean, the details of the regression analysis is not available, but yes, they have mentioned that they used regression analysis to derive the independent predictors of non-adherence. So coming to the conclusion, so poor adherence to therapy or prescribed medication is not just forgetfulness. Let us not say that just because somebody forgot, that is why he has not taken. There are a lot of other things as we see. Depression is the paramount factor affecting adherence, along with adverse drug events and irregular follow-up. And this calls for screening, especially in elderly patients. And medication adherence should be evaluated at each clinic visit, especially before modifying the therapy. And thinking of non-response, first we should evaluate the compliance. I think, yeah, that is the end of the presentation. So
very nicely put through. I just had one question. Did they look at the apathy scale in this PD?
No, ma'am. No, ma'am. They have not mentioned anything to the effect, or that they did not look at the apathy scale. But what they did, ma'am, was they have excluded everybody with cognitive dysfunction. That is what they mentioned. They have not mentioned that how they did it. I mean, which scale they used, or whether it was only apathy or dementia. I mean, they've not mentioned. They've said it as only cognitive dysfunction was an exclusion criteria. Okay.
I mean, was there any financial constraint which made them choose or have a partial adherence compared to a complete adherence?
No, madam, what they have done was in the Kuppuswamy scale, they found out that actually it has got little to do with the income status. Patients who had, even people who were in the rural areas and they were of low education, they have said that if they had a good follow-up and if the treating physician could tell them every time that your compliance is important, they have found out that there is no relation at all between the income, the socioeconomic status, and the adherence to therapy.
Just a quick question. Does NIMHANS provide the medicines to these patients? You have worked in NIMHANS, so that's the reason I'm asking you.
Ma'am, what happened was in NIMHANS, this study is done at Ludhiana, but in NIMHANS, what they used to do was for patients who were in the who were in the BPL category, and especially the dopamine agonists, which were expensive. So we used to have a NGO which used to provide these drugs in bulk, and we had a point person. We used to contact him. He used to ascertain the financial details, and then he used to provide them, especially dopamine agonists.
Yeah, because they've not mentioned about the financial status, availability of the drugs to the patients.
Madam, what they have done was they have mentioned about the socio-economic class, but they have not mentioned very specifically, but they have said that the socio-economic class has not had any difference in their analysis, statistical analysis. This is something new. I mean, as compared to, there is another interesting aspect to this is in the West, when they did the study, people who were in a job, they used to take their medicines very regularly because they were unable to perform their work if they are not on drugs. So that was something, but the reason they have not mentioned why, but I think it could be just that those who are maybe compliant and have a regular follow-up, and their physician who is educating them at their each visit, they tend to be compliant in spite of maybe financial hurdles.
Yeah, I think so. That's so. And probably they make the patients aware that there are some avenues available to get the treatment free of cost.
Correct. Absolutely.
That makes a lot of difference in the financial burden.
Ma'am, we have a question from Rishikesh, sir. So sir asked, treatment adherence depends on the particular medicine like levodopa or dopamine agonist, and also the level of disability. So was this addressed in this paper?
Yes. So what they try to correlate the HNY stage and the UPDRS score with the drugs, but there was no correlation. There was no association. One of the reasons could have been that most of these patients, what they do before they come to the doctor, they pop in a pill and come. They try to show that they are adherent just before coming to the doctor. So maybe that is one, I mean, maybe that could have been something which is inaccurate, that their UPDRS scores not correlating with their, compliance.
So actually UPDRS score in an advanced PD can fluctuate quite a lot.
Correct.
So that again, that score has that point score. It's at a time score. It doesn't
Exactly.
tell you how severe the disease is. It's a Hone and Yar which tells you how severe the disease is.
Correct. Correct.
There's one more thing. I feel that advanced PD patients tend to adhere better because
Correct.
otherwise their off periods are so bad and they're not able to function. So they tend to be very, very obsessive about their dosage schedule. So it's it's a little surprising that the authors didn't find this to be a factor in adherence and non-adherence.
Correct. And they didn't find it explicitly. They've mentioned that there was no association. I mean, maybe
it's a little surprising that
we have also found is that sometimes the patients, like, they get used to things like trihexyphenidyl, and then they won't adhere to the medication that you're probably writing to them. They'll just go back to the original trihexyphenidyl. This has happened to a lot of my patients. I'll ask them, like, I would be probably writing some 4 tablets of levodopa. They will just say, I'm taking 1 tablet or 2 tablets if you ask them seriously. Because I look at them and then they will be like, I'm on 3 tablets of Pacitane. So I think, so the question on the chat box is also that, do you think there is a difference between the type of medication? I think that's not addressed in the paper, whether it's levodopa or dopa agonists.
Correct. They have not made a mention of that in the results, although they have mentioned that a particular, if we see the slides, in the beginning, they have just made a brief mention that, I'll just come, yeah. So this slide, wherein they have mentioned that, 94% of the patients were prescribed levodopa therapy with or without other dopaminergic drugs. So at least they were on levodopa, but they could have been on other drugs as well, while 32% of them were taking at least 1 dopamine agonist. But the difference in adherence of this group has not been mentioned in the study. What was the difference with regards to adherence?
Okay, so adherence can be on both sides. It could be over adherence, like impulse control disorder, and so they have fortunately taken out the patients who had.
Yes, they have already excluded them, ma'am. Yeah.
There are a lot of factors which will affect this study actually, and it's very difficult to address all the factors in this particular group of adherent patients and the non-adherent. I think in practice we see a lot of things, but when we actually sit down to look at it and do the study, we find very surprising results actually.
Correct.
Surprising results when we've done studies in our clinics.
Another thing was that, a brief mention was that what happens is that in the West, they found out that people who are married, who have a spouse, they have better compliance.
That's correct.
But in India, you have like, even if you're not married, you have the joint family and everybody looking out for you. So that also did not make any difference. Because of the sort of social and differences. So even people who are unmarried did well in this study.
I think their numbers, if they were larger, then they would have got probably different results.
Maybe, yes, ma'am, maybe.
Yeah. Okay.
Dr. Rishi is actually kept his hand up for a long time.
Shall we move on to the journal blast now? I think
Dr. Rishi actually has been waiting to ask a question or have a comment.
Sure.
First of all, Dhruv, we are happy that you don't have a resident because you presented very well, very crisp.
Thank you.
And that can work as a model for future presenters also.
Privileged to hear it from the faculty.
Absolutely.
And second thing, I would say that from study point of view, I just want to convey to the residents and junior people that for a good study, question is important. You don't need to have multi-crore lab to have good study. This is wonderful study. At least the notion was wonderful. Means small thing that adherence depends upon depression. You treat depression, you address depression, adherence may improve. So these are small things, but very important clinically. So good study doesn't require a lot of money. It's a question that's more important.
Correct.
And so
At
these
this
two
stage, there were more patients in the study. That's what to be very sure of these factors.
Correct.
But I agree with Rishi. I think the fact that depression can make a lot of difference
exactly.
was highlighted in this study. It's really good to know, and maybe we'll address depression in Parkinson's disease a little bit better in the future, probably.
Thank you.
So, do we want to move on to the journal blast from the NIMS group?
Yes, ma'am.
So it's it's a pleasure to actually invite Dr. Shruti, who's a fellow, first fellow of Nizam Institute of Medical Sciences. So for us, it's a big achievement and a big step forward to give the journal blast.
Thank you, ma'am. I'm sharing my screen, ma'am. Is it visible, ma'am? My screen?
Yeah, it's visible.
Good evening, everyone. Today I'm going to discuss about the 4 journals. The first journal is about the clinical, biochemical, radiological, and genetic profile of patients with homocysteine remethylation pathway defect and spastic paraplegia. It was published in Indian Academy of Neurology. An introduction, that's as we know that homocysteine is a sulfur containing amino acid and it is produced in the body mainly through essential amino acid like methionine. And homocysteine usually metabolized by 2 pathways. One is through remethylation and another is through transsulfuration. Through remethylation, it is metabolized to methionine, and through transsulfuration, it is metabolized to cystathione. And the enzymes most commonly required in the pathway of remethylation were the methionine synthase enzymes, methionine synthase reductase, and methylene group transfer from the 5-methyl tetrahydrofolate. And this transfer requires methylcobalamin as a cofactor. And there is another pathway for remethylation that occurs independently in the liver, that is from the conversion of betaine to dimethylglycine by betaine homocysteine methyltransferase. So these are the 2 alternate pathways.
Would you mind shifting from presenter's view to the full view? We're not able to really clearly see it.
Okay, ma'am. Sure, I will change it.
Yeah.
No, ma'am. Is it visible, clear?
Better.
Okay. So this remethylation of homocysteine prevents this toxic accumulation of the homocysteine in the brain, heart, eyes, and skeletal system. And biochemically, what is increases serum total homocysteine levels with low or normal serum methionine usually differentiates the disorders from remethylation from transsulfuration. And this remethylation pathway defects can also can present across any age group from infancy to adulthood, and manifestations are very diverse. So these remethylation defects can present in neonates and in adults. In neonates, usually the common manifestations are like poor feeding, failure to thrive, encephalopathy, seizures. And in adults, usually present with neurocognitive impairment, visual impairment, and features of like subacute combined degeneration of cord. And the spastic paraparesis, which is the main topic here, it is due to remethylation disorders, can usually seen in adolescents or adults, and it can be easily treatable, but it is usually misdiagnosed. And the study design here is, it was a retrospective study, and they took and taken as elevated serum homocysteine levels was defined as which is more than 50 micromoles per liter. And inclusion criteria they taken was patients present with progressive spastic paraparesis and who had elevated homocysteine levels that is greater than 50 micromoles per liter, and who had low or normal blood methionine levels, thereby suggesting the disorders of homocysteine remethylation. So this is the main important because they should have normal methionine levels are low with elevated homocysteine levels, so that it is suggestive of disorders of homocysteine remethylation. And exclusion criteria were the patients with other secondary causes of spastic paraparesis like compressive myelopathy, demyelination, and other deficiency disorders or cerebrovascular disorders. They excluded these patients. And data, they collected demographic details, clinical features, and complete blood count and peripheral blood smear, B12 levels, folate, homocysteine levels, and they did the MRI of the brain and spine, and exome sequencing was done, and other laboratory parameters were done to exclude the other secondary causes of homocysteine deficiency. And the results were, they included total 7 patients. They fulfilled the inclusion criteria and were selected. And this is a basic demographic profile of the patients. And usually that included 7 patients, and most of them, the most common presentation was the recurrent falls and gait impairment in almost 4 of the patients. Only 3 patients, they presented with encephalopathy and behavioral and seizure disorders, and most of them have recurrent falls and gait impairment. And other clinical features they observed was the cognitive decline in 4 patients and bladder disturbances in 1 patient. And all the 7 patients were had spasticity in the lower limbs with exaggerated reflexes and extensor plantar. And biochemical parameters, all the patients had homocysteine levels that is more than 100. They found all the 7 patients had more than 100 homocysteine levels, and B12 levels were lower than normal range except in 1 patient, that is in second patient is 230, and remaining all the serum B12 levels were low. And in MRI brain, all the patients had posterior predominant periventricular leukoencephalopathy except the 2 patients. And 3 patients were found to have mutations in the methylene tetrahydrofolate detectase gene. And these are the MRI images. Almost all the 4 patients, they have shown the symmetric periventricular hyperintensities in periventricular hyperintensities shown in the bilateral frontal, parietal, and parieto-occipitals and semi-oval regions. And 1 patient, it has he had diffuse brain atrophy with hyperintensities in the peritrigonal area. And the treatment they followed was, all the patients received injection hydroxycobalamin, oral pyridoxine, and folic acid, and methylcobalamin, and baclofen. And 2 patients who were able to procure P10, they received it at 250 mg per kg per day. And follow-up, all the patients reported improvement in spasticity, and 1 patient also had improvement in the behavioral symptoms. And the median serum homocysteine levels was 108, that was less than pre-medical values, and the duration of follow-up was around 12 months. And coming to the discussion, the study actually included the 7 patients who have presented with progressive spastic paraparesis due to remethylation pathway defect of homocysteine, and all were adolescents and presenting subacutely with progressive spastic paraparesis, and only 1 patient had acute presentation with recurrent encephalopathy, and other manifestations they presented were cognitive decline, poor scholastic performance, behavioral disturbances. And all the patients in this study have homocysteine levels greater than 50, and with 86% of them having severe hyperhomocysteinemia, and 14% had intermediate, and 100% had normal methionine consistent with disorders of homocysteine demethylation. And the serum B12 levels, they found it was low in 6 patients, and they have found no evidence of any megaloblastic blood picture in the peripheral smear, and all the patients were treated with hydroxycobalamin. And 3 out of these 6 patients who were having low B12 levels were genetically confirmed to have the mutations in the methylene tetrahydrofolate gene. And another 3 patients with the low B12 with no genetic testing they had persistent high homocysteine levels despite the normalization of B12. So this suggests that they belong to remethylation defect. And so thus the persistent elevation of serum homocysteine despite normalization of B12 levels points towards non-nutritional or genetically mediated cause of hyperhomocysteinemia. And the imaging abnormalities described in remethylation defects include diffuse cerebral atrophy, white matter changes, basal ganglia lesions, and hydrocephalus. And this leukoencephalopathy has been hypothesized to be secondary to the maybe interference in the process of myelination by the failure of methylation of myelin basic protein. And the genetic analysis in the first 3 patients, they show the missense variants in the methylene tetrahydrofolate detectase gene. And this is the second most common cause of remethylation disorders next to the cobalamin defect. And this hydroxycobalamin, it is a cofactor for methionine synthase and betaine. By using these two are the usually proven modalities of treatment for patients with remethylation disorders. So all the patients received hydroxycobalamin and only 2 patients received betaine. So finally, at the follow-up of 12 months, all the patients were symptomatically better with improvement in spasticity, and one patient had improvement in behavioral symptoms also, and also there was reduction in the homocysteine level by 77.5 micromoles per liter at the end of the 12 months. So the strengths of this study include a well-defined inclusion and exclusion criteria with only homocysteine remethylation disorders, and detailed description of clinical manifestations, biochemical and imaging findings, and had a median follow-up of an year. And the limitation is its retrospective nature and small sample size, and they did a genetic confirmation only in the 3 patients. So this conclusion, this remethylation defect of homocysteine is one of the very few treatable metabolic causes of progressive spastic paraparesis. So any patients who are presenting with progressive spastic paraparesis, so any patient who is presenting with progressive spastic paraparesis, by simple measurement of this homocysteine and blood methionine levels, we can identify this remethylation defect, and by treatment with hydroxycobalamin, these patients can have improvement, and it gives a clue to the treatable causes of this spastic paraparesis. This is the first one.
Go ahead, Jyoti. I mean, I think the discussion can be continued.
Okay, ma'am. And the second journal was about the multimodal imaging and visual evoked potentials reveal the key structural and functional features that distinguish symptomatic from pre-symptomatic Huntington's disease brain. As we all know that Huntington's disease is an autosomal dominant inherited neurodegenerative disorder. It is usually caused by the CAG trinucleotide repeats, and with the onset of around 40 years. And it usually contains greater than 39 CAG repeats. It produces a mutant Huntington protein that aggregates and causes a neuronal degeneration. And this Huntington's is usually characterized by progressive involuntary movements, that is predominantly chorea, cognitive decline, and behavioral abnormalities that usually determined by the CAG repeat length. Currently, this matched analysis of structural and functional differences in the brain from the same study cohort, especially in the HD patients, were lacking from the Indian population. So this study was aimed mainly to understand the structural and functional differences between the Huntington's disease and control patients' brain, and also between the pre-symptomatic and symptomatic HD patients in Indian population. So the methods were, they included 17 patients. Among the 17 patients, 11 were symptomatic patients and 6 were pre-symptomatic patients, and 12 were healthy controls. To distinguish between the symptomatic and pre-symptomatic patients, they took the chorea, they assessed the chorea in 7 different body regions, and they did the total chorea score. And these neurologically healthy control patients, 12 healthy control patients, among them 3 were the genetic controls and 9 were age gender matched controls. And to know the structural difference, they did the macrostructural, microstructural, and functional analysis, that is imaging of the brain was done to determine, and also with the visual latencies. And this is the table showing the demographics. Among the 17 patients, 11 patients with they had the CAG repeats of 49, with the total chorea score was 17, and that included as a symptomatic Huntington's disease patients. And another 6 patients with the CAG repeats of mean value of 46 with no any chorea symptoms, they have included as pre-symptomatic HD patients, and remaining 12 patients they have taken as controls. And what they found was that within the symptomatic Huntington's disease patients, they found a strong inverse correlation between the CAG repeats and the age at the onset of age at onset. That is, the patients with CAG repeats of more than 50, they had an early onset of around 23 years, and who had the CAG repeats of around 40 to 50, they had delayed onset of presentations around 38 years of age. And this total chorea sum score also in symptomatic patients were positively correlated to the age at onset, and it is negatively correlated with the CAG repeat length. So what they found was a strong correlation between the number of CAG repeats and with the manifestation of clinical symptoms with patient age. And VGP analysis, it clearly shown that between the control and HD patients, the P100 latencies were prolonged in Huntington's patients. And even within Huntington's patients, this P100 latency was much more prolonged in symptomatic patients when compared to the pre-symptomatic patients. Here also we can see that controls were having, compared to the controls, these HD patients were having prolonged P-wave latencies, and among these two also symptomatic patients have a much higher prolonged latencies when compared to the pre-symptomatic. And this is the MRI. They have found that there is a atrophy of the bilateral caudate and putamen atrophy in both in HD patients when compared to the control patients. And also within the HD patients, the symptomatic patients have much more atrophy than when compared to the pre-symptomatic patients. And finally, within the ratios like frontal horn with inter-caudate distance, they also found the ratios are much less in symptomatic and pre-symptomatic patients when compared to the controls. And the ratios with caudate distance and inner table width are significantly higher in HD patients when compared to the controls. And volumetric analysis, they show that there is a reduced volumes in subcortical gray matters in Huntington's disease patients when compared to the controls. They're showing that the volume is much lower in HD patients when compared to the controls, and subsequently, then even the caudate, putamen, accumbens also, they are shown the much less volume in HD patients when compared to the controls, and within the HD patients also, the volumes are much lower in symptomatic when compared to the pre-symptomatic patients. And to know the microstructural alterations, they did the diffusion imaging. And in diffusion imaging, they found a significant decrease in the fractional anisotropy and increase in the mean diffusivity, axial diffusivity, and radial diffusivity in cerebral white matter and subcortical regions in HD patients when compared with the controls. And also, they found the increased diffusivity in the caudate and putamen and pallidum hippocampus, as well as cerebellum in symptomatic patients when compared to the pre-symptomatic patients. And to know about the effects of neuronal degeneration on the neurochemical changes and glucose metabolism, and they performed MRS and FDG PET, and they found that NAA was significantly reduced and choline levels were significantly elevated in HD patients when compared with the controls. And with regard to the glucose metabolism also, it was reduced bilaterally in the caudate in HD patients. So, coming to the discussion, in neurodegenerative disease like HD, there will be aberrant cellular signaling cascades, and these signaling cascades will lead to neuronal cell death that ultimately results in tissue atrophy. And these abnormal signaling cascades, they lead to abnormal metabolism, and these can be found by using functional imaging techniques like PET or MRS, and to capture these early metabolic changes in the Huntington's disease brains. And they observe that reduced consumption of glucose and lower levels of NAA, elevated levels of choline in symptomatic and both pre-symptomatic and symptomatic patients when compared to the controls. Even without the onset of clinical symptoms also, these pre-symptomatic patients have shown the reduced levels of glucose and lower levels of NAA and elevated levels of choline. And this neuronal degeneration usually causes alterations in the gray and white matter integrity, and they cause the demyelination and axonal damage. And these alterations can usually increase the Brownian motion of the water molecules and lead to increased diffusivity and decreased anisotropy. And this to identify this, they found in diffusion analysis, they observed that increase in the mean diffusivity, axial and radial diffusivity, and decrease in the fractional anisotropy in subcortical regions of the HD brain. And this axonal demyelination, to know this axonal demyelination, they did the optic pathway conductions, that is VEPs, and they found their prolonged latencies in Huntington's patients. So, conclusion, the study provides the clinical relevant insights into structural, functional, and metabolic features of the Huntington's brain. And patients with symptomatic patients had a significant volume loss, increased diffusivity, and altered neurochemical profile, and delayed P100 latest when compared with the pre-symptomatic patients. So, changes between these two symptomatic and pre-symptomatic patients, they provide usually they suggest that the manifestations of clinical HD patients some of which could be further developed into imaging markers. Like even before the manifestation of clinical features, we can observe these changes in the imaging. So these can be developed into imaging markers to monitor the progression of patients who are harboring the CAG repeats. So the development of such type of monitoring tools will allow the further testing of therapeutic approaches that can delay the onset of clinical symptoms in these individuals. So if we before developing the clinical features, if we know these volumetric loss or these imaging features, these can be used for in the future to know the therapeutic approach so that they can delay the onset of clinical symptoms. And coming to the third journal, it is about the anteroposterior stability. a determinant of gait dysfunction and falls in spinocerebellar ataxia. Like the patients with SCA are usually more prone to falls and with greater episodes of near falls. And 75% of these falls are often lead to injuries and subsequent prolonged hospitalization. And because of this, fall and fear of fall also may impose severe mobility restriction, and it may be more dependent on family members or caregivers. So if we establishing this association between this gait variability and direction specific balance indices, usually help in identifying the patients who are at risk of falls in SCA patients, and it may help in developing appropriate interventions. And this study was aimed mainly to identify the association between this balance and gait parameters, especially the gait variability in patients of spinocerebellar ataxias. And methods. Patients with genetically confirmed SCA were recruited, and patients in the age group of 20 to 70 years of both gender who were able to ambulate independently or with assistive devices for a minimum of 10 meters were included in the study after obtaining the consent. And patients who were unable to undergo the test, that is maybe because of severe mobility disturbances or the presence of concomitant other neurological illnesses or any other significant medical or orthopedic problems, who are unable to ambulate, and also who are having significant vision problems, were excluded from this study. And controls like healthy adult individuals in the same age group of 20 to 70 were considered as controls. And the gait measurements, these gait parameters, they assessed by using the Gait-Right electronic walkway system. And this is the composed of 7 meters mat with embedded sensors that colors the spatial and temporal parameters. A minimum of 4 steps was recorded to assess the variability of gait parameters. And the parameters they studied like functional ambulation profile, velocity, cadence, step length, step time, and they have taken the stride length and heel to base support. And this gait variability was also assessed as the coefficient of variation of spatial and temporal variables of step and stride. And the balance measurements, the balance parameters were assessed using the Biodex balance system. And the system is usually equipped with a circular platform that can move freely in the anteroposterior directions and mediolateral axis, allowing a 20 degrees of tilting from horizontal in all directions. And they did assessment of overall balance index, as well as within the overall balance index, they took the anteroposterior index and mediolateral sway index also. And 3 test trials were done, and they took the average of 3 records. A high score recorded in various sway parameters indicates increased sway and poor balance. And disease severity, this is used in the International Cooperative Ataxia Rating Scale. And the results, they included total 48 patients, out of which 24 were the controls and 24 were the subjects. And the duration of illness they found was 5.67 years. And among the 24 patients, 4 were SCA1, 12 were SCA2, 5 were SCA3, and 3 were SCA12 patients. And the results comparing the balance indices, they found that overall balance index, anteroposterior index, and mediolateral index were all higher in SCA group patients when compared with the control group patients with a significant difference, with p-value significance. And among the API MLI, they found more difference between the more values in the anteroposterior index when compared to the mediolateral index. And this is the comparison between the gait variability and the balance indices. And the first one is in the SCA group, and second diagram is the control group. And the SCA group, they found that positive correlation between the, that is gait variabilities, they took the correlation variation of step length and balance indices. And they found positive correlation between the overall balance index and anteroposterior index, but they did not find any correlation in the with regard to the mediolateral index. So only overall balance and the API was found to be positively correlated with these gait variabilities, but not the mediolateral index. Whereas in control group, all the 3 balance parameters like overall balance index, API, and MLI, all the 3 were positively correlated with the gait variabilities. So coming to the discussion, as well known that human gait is a product of efficient static and dynamic balance measures. A reduction in the balance performance may directly affect the ambulation. So usually for this, the cerebellum helps in scaling of responses produced by the body to counteract for the postural perturbations. So an inability to judge this magnitude of responses for predicting the perturbation causes the imbalance with an overshooting of the responses. And this dysmetry and the postural responses along with the prolonged muscle activity also are detected in individuals with cerebellar damage, causing an incoordination in the combined multi-joint movements. So this may have an impact on the coordination that is required between the trunk and limb girdle in locomotion. So this study identified that in the balance performance measures under consideration, this anteroposterior instability index was much higher in the SCA group and compared to the mediolateral index with a mean difference of 0.55. So when this mediolateral index did not correlate with any of the gait parameters, but when comparing the gait parameters, the MLI did not show any correlation, but API showed a significant correlation with 9 out of 21 gait parameters. And these increased AP displacements have identified to be a strong predictor of the incidence of falls. And this may explain the gait dysfunction experienced by the SCA patients. And limitations like they included various subtypes of SCA, and the result cannot be generalized. And the number of subjects they had taken was also very less, and hence the subgroup analysis was not possible. And they did not do the dual task program. And conclusion, finally, they found was the significant relation between the gait characteristics and postural instability that is mainly oriented in the anteroposterior direction than the mediolateral direction. So if we do the early screening of patients with neurological deficits and we identify this API-oriented instability, so if we do the exercise protocols mainly focusing on this API stability, we can improve the gait and then we can reduce the falls in these patients. So future studies can contemplate if the management and exercise protocols focusing mainly on improving this API stability may improve the gait parameters as well as the reduction in the falls mainly in the SCA patients. And coming to the last journal, that is the discordance between the patient-reported outcomes and physician-rated motor symptom severity in early to middle stage spinocerebellar ataxia type 3.
Shruti, I think you just give the gist. We are already running a little short of time.
Yes. Mainly the aims of the study was to identify these patient-related outcome measures like quality of life, depressive symptoms, fatigue, and physical activity in mildly to moderately affected SCA patients, and to examine the relation between these prompts and disease objective disease severity indices. And they enrolled 20 patients, and disease severity measures they took was SARA and ENAS, that is scale for assessment and rating of ataxia and inventory of non-ataxia signs. And these two are the disease severity measures. And patient-reported outcome measures they taken were 4, that is EQ-5D, patient health questionnaire, profile of mood states, and international physical activity questionnaire. These are the 4 measures that are taken in the prompts. And coming to the results, among the 5 health domains, they found the significant difference between the SCA and healthy controls in case of mobility, self-care, and usual activities. And they did not find much correlation between the pain, discomfort, or anxiety or depression between the 2 groups. And coming to the depressive symptoms, the sum scores were higher in SCA3 patients when compared to the healthy controls. Overall, the depressive symptoms are more in the SCA patients. And mood states, like they found the significant depression, that is they found more depression, more fatigue, and less vigor in case of SCA patients. And in case of anger and tension, they did not find much significance between the 2 groups. And physical activity, regarding the physical activity like walking, moderate intensity exercise, and vigorous exercises, they did not find any much significance between the controls and the SCA3 patients. Almost both groups have the similar physical activity. And what are the associations they found was these health-related quality of life and depressive symptoms were associated with the disease duration, but not with the SARA score. And the fatigue also did not associated with the SARA score or ENAS count. And the lower quality of life was related higher to the higher levels of fatigue. But in contrast, the physical activity was inversely correlated with the SARA score, but not with the fatigue. So the predictors, what they found was fatigue was found to be fatigue was the one which is affected with health-related quality of life. And physical activity was predicted by SARA score. And fatigue and disease duration were independently associated with the depressive symptoms. Taken together, what they found was that in lower quality of life, more depressive symptoms, and higher levels of fatigue in SCA patients when compared to healthy controls, and amount of physical activity did not differ between the 2 groups. And linear regression analysis, they revealed that quality of life was primarily determined by fatigue and not by ataxia, while physical activity was independently associated with the SARA score and ENAS count. And depressive symptoms were related to disease duration and fatigue, but not to the markers of motor disease progression. Coming to the discussion, what they found is the quality of life was slowly driven by the fatigue and not by ataxia severity or degree of extracerebellar involvement. And depressive symptoms also they found more common during the early stages of SCA3. And I will skip this. And what is the final conclusion was this? These early stage SCA patients, they already experience this lower health related quality of life and more depressive symptoms. And it is independent of the severity of ataxia. It won't depend on ataxia severity, and it is mainly depending on the depressive symptoms and fatigue. And it is only determined by the fatigue, but not with the ataxia severity. So therapeutic strategies that specifically target this fatigue may be useful to enhance the ataxia patient's well-being. And physical activity, on the other hand, is not associated with the fatigue, and it is dependent on the SARA score INAS count. And this self-reported physical activity can be useful as a marker for motor impairment in a home setting. And this lack of correlation between depressive symptoms and ataxia severity or extracerebral involvement, the mood disturbances is mildly do not respond to motor dysfunction. They are mainly dependent on the fatigue and disease duration, but not correlated with the ataxia severity. Thank you.
So that was very nicely done, Shruti.
Thank you.
Just
Yeah,
quick question. In that homocysteine study, did they do methylmalonic acid?
They did those levels, ma'am. They were normal or low?
Methylmalonic acid.
Yes, ma'am. They did.
Find any correlation between the methylmalonic acid and homocysteine levels?
They did not do that correlation, ma'am, between those two levels.
So, methylmalonic acid is more sensitive than vitamin B12 levels of the B12 deficiency. So that's why
they measured the levels, but the correlation they have not done, ma'am.
B12 levels are not very reliable, and they don't correlate with the actual deficiency of the.
Yes, ma'am.
Ma'am, with permission, can we move to the case discussion?
Yes.
Yeah.
How many cases are there?
One case, ma'am. One case. I request Dr. Arun, who's second year resident, to present the case. 10 minutes.
Good evening, everyone. I am presenting a short case vignette here. Yes, here is a case report which was published in Annals of Movement Disorder in December 2021. It is about a PIGG gene mutation associated with Uniter-Tan syndrome. First case report associating PIGG gene mutation with Uniter-Tan syndrome. So the next. As you know that the habitual quadrupedal gait, it is usually evolutionarily applied, and it is seen in non-human primates. So in humans, the quadrupedal gait, which was habitual, was first described as a trait of Uniter-Tan syndrome, in which the affected individuals ambulated using their palms and feet. There are two types of quadrupedal gait, either diagonal or lateral. So this Uniter-Tan syndrome also associated features like impaired cognition, dysarthric speech, and cerebellar hypoplasia. So it is a clinical syndrome with genetic and phenotypic heterogeneity. There are various genes have been described for this Uniter-Tan syndrome, and in this case, they have identified a novel gene, that is PIGG gene mutation, associated with clinical phenotype of Uniter-Tan syndrome. Next slide. These are the genes which I was telling. The initial case reports had VLDL receptor was the first one which was detected in Uniter-Tan syndrome, and the other genes that were known to be mutated were CA8, WDR81, ATP882, and TUBB2B. In this report, it is a case of a patient exhibiting quadrupedal locomotion and other clinical features similar to UTS, that is caused by a mutation in PIGG gene. So the case description goes like this. This was from Belagavi from Karnataka that was published. So the patient here had a global developmental delay, had facial dysmorphism. She had skeletal deformities like planus also. And clinically, she had non-progressive cerebellar ataxia and intellectual disability, gross mental retardation, and Most of the cases described for Una Tanner also will not have any speech. And she had history of 2 isolated seizures during childhood. And she developed a quadrupedal locomotion by the age of 6 years. And by the age of 11 years, brief stretches of bipedal locomotion was also developed. So this is the family tree, where you can see that it's a second degree consanguineous parentage. She was our father has married his sister's daughter, and she is the patient here, second born child. Next. So this basically with these patients, they will be having ataxia when they walk through the bipedal locomotion. So they will develop this quadrupedal locomotion, which will become habitual. And it is, as I told you, there are 2 types, the diagonal and lateral. In this case, they are typically diagonal sequencing, where they will have initially when one foot they keep and a contralateral palm they will place. That's the diagonal sequencing. And they use the palmigrate placement of the upper extremities. And this patient also had the typical MRI features in Unit 10 as in previous case reports, that are cerebellar hypoplasia and simplification of the cortical gyri. So this we can see the cerebellar hypoplasia in the sagittal section, and simplification of the cortical gyri we can see. And the thing is, they have preserved extrapyramidal symptoms like basal ganglia, thalamus, and brainstem will not have any, will not be much affected in these patients. Next. So in this investigation, further investigating, the clinical whole exome sequencing was done, and which identified homozygous 2 base pair deletion in exon 12 of the PIGG gene, and which resulted in a frame shift mutation and premature truncation of the protein, which is described by that codon. So after whole exome sequencing, it was confirmed by Sanger sequencing, which was done for all. That is for the proband and the asymptomatic parents, and also for the younger brother. So for the patient, it was in the homozygous state, but for these 3 relatives, it was in the heterozygous state. As it is an autosomal recessive inheritance, the proband had manifested the disease. This is the same. This is the proband one, and these are the sequences, chromatogram sequences of father, mother, and also the sibling, younger sibling. So this is the video. So the patient also has facial dysmorphism. Here is, we can see she is ataxic while walking. So, but when she is walking by this quadrupedal position, ataxia is not there. And she is using the diagonal sequence. Next. So coming to the discussion, the PIGG gene mutations, which were previously described genetic neuroimaging and clinical presentations, so were all similar, but nobody had described that quadrupedal locomotion in PIGG gene mutations. There was a study by Mark Etherson et al., who reported 5 individuals with PIGG mutations, and all of them had intellectual disability, hypotonia, and early onset seizures. But in case of Unert-Tan syndrome, the seizures had not been described. And but none of the families with the PIGG mutation previously had quadrupedal locomotion. And next. And MRI features of like PIGG mutations in the study which I described now, which I told now, were normal in case of Japanese individuals, and in 2 Egyptian individuals, they had thin corpus callosum and asymmetry of lateral ventricles. Cerebellar hypoplasia and mild cerebral atrophy was found similar to Unert-Tan syndrome that was there in 2 Pakistani individuals. Next. So this PIG gene family is involved in the biosynthesis of glycosyl phosphatidylinositol. This is a lipid anchored membrane protein that is present in almost all the cells of the eukaryotic cells. So their main function as they have in the receptors among all other functions, their main function in the embryogenesis, neurogenesis, and also in the priondices pathogenesis. So this is a novel gene mutation which has been described in the genetic profile of the rare Unner-Tan syndrome. Next, also a few points about Unner-Tan syndrome. It was first described in 2005 and 2006 in Turkish families initially. It's a clinical syndrome with genetic and phenotypic heterogeneity, as I have told. So it mainly comes under non-progressive autosomal recessive cerebellar ataxia. The characteristic clinical feature of this syndrome is habitual quadrupedalism, which is a diagonal type of quadrupedalism with speech abnormality and intellectual disability are the triad of this. And imaging wise, they'll have cerebellar hypoplasia, gyral cortical simplification, thinning of corpus callosum, with sparing of the basal ganglia brainstem, relatively spared. Next. So the main pathogenesis in the previous studies, they have detected in the central and vestibular, peripheral vestibular system, where they can have the balance and ataxic problem. And this quadrupedal locomotion is a self-adaptive motor behavior where they will find comfortable in walking in the quadrupedal position, which has been described as a dynamic system adaptation. Also as a reverse evolution theory, where going as a describing this Unner-Tan syndrome as a phylogenetic disease. Initial pathogenesis was that the thing VLDLR was the main one which is required in the neuronal migration. So that is involved in the pathogenesis of this disease. And the differential diagnosis they described was the disequilibrium syndrome with cerebellar hypoplasia and Cayman syndrome for this Unner-Tan syndrome. Thank you.
So the enigma of Unner-Tan continues. At least we now have one genetic mutation.
Yes.
I don't think there are any questions actually, but Unner-Tan used to be one really exciting entity for a long time.
But I don't think it's a single mutation that can explain this entity. I think there are multiple mutations which will probably. I think the basic pathology may be ataxia, and then this is a compensatory mechanism to overcome ataxia or triple gate. Any comments from Rupam? He's joined now. No, no. Shall we then wind this session? Excellent presentations from all.
I just wanted to apologize. My phone was, the internet connection had gone. I just couldn't get. I was traveling on the road, so I just couldn't connect. I'm sorry about that.
No, so excellent presentation by all the presenters.
I saw the last one.
Enjoyed it, yeah. We got to see an interesting case and its explanation, Unner-Tan syndrome, by the last presenter as well. So shall we wind this?
Yes, ma'am. So thank you everyone. On behalf of MDSA JQ team, I would like to thank all the presenters, Dr. Dhruv, Dr. Shruti, Dr. Arun, and the chairpersons for a wonderful session today. So till we meet next time, it's good night, goodbye, take care.
Thank you so much.
Thank you again.
Bye.
Bye.